Hi, my name is Scotty. I'm a student nurse with the University of Charleston in Beckley, West Virginia. And today I'd like to speak with you about Cushing's disease, which is also known as hypercortisolism. This is a result of a tumor in the pituitary gland that results in the excessive release of the hormone ACTH. This is the major pituitary hormone that regulates adrenal function. ACTH then stimulates the adrenal cortex to increase the secretion of the glucocorticoid hormone cortisol. Cortisol is produced in the pituitary gland and is regulated by the ACTH. When functioning correctly, cortisol helps the body to respond to stress and changes, as well as mobilizing nutrients, modifying the body's response to inflammation, stimulating the liver to control blood glucose, and the amount of water in the body. This results in hyperplasia of the adrenal cortex. The ensuing tumors that may develop can be either benign or malignant. In 1932, American neurosurgeon Harvey Cushing, who is also known as the father of neurosurgery, described Cushing disease as a disease restricted to patients in whom the symptoms and signs are caused by an adrenocorticotropic hormone secreting pituitary tumor. Among patients with spontaneously occurring Cushing syndrome, about 70% have Cushing's disease. A major risk factor of Cushing's is women between the ages of 20 and 40 years. Too much cortisol can produce some of the hallmark signs of Cushing's, such as changes in fat distribution, like the moon face, truncal obesity, pink or purple stretch marks on your skin, petechiae, thinning hair, acne, red cheeks, and fat collection on the back of the neck known as a buffalo hump. Cushing's can also result in tachycardia, hypertension, bone loss, and on occasion, type 2 diabetes. There may also be evidence of decreased immune function and decreased inflammatory response, such as infections without fever, swelling, drainage, and erythema. The diagnosis of Cushing's is based on clinical suspicion combined with a review of the patient's medical history, physical examination, and laboratory tests to help determine the existence of excessive levels of cortisol. A patient suspected of having Cushing's must initially have an appearance suggestive of excess cortisol production, combined with an elevated 24-hour urinary excretion of cortisol. It may also be helpful to compare old and recent photographs to reveal any changes in facial and body appearance associated with this disorder. Some tests that may be conducted to determine a diagnosis of Cushing's are a 24-hour urine collection, which contains levels of free cortisol, a blood plasma level, which is the ACTH. Salivary cortisol elevations confirm the diagnosis of Cushing's disease as well. Dexamethasone suppression test determined Cushing's through suppression versus non-suppression of cortisol excretion. Some expected lab findings that indicate Cushing's are an increased blood glucose level, an increased sodium level, and lymphocytes are typically decreased. Some diagnostics that can be run for Cushing's is an X-ray, an MRI, an arteriography, CT scans, which can identify lesions of the pituitary gland, the adrenal gland, the lung, the GI tract, and the pancreas. Radiological imaging determines the source of adrenal insufficiency, such as a tumor or atrophy. Some complications may be a perforated viscera or ulceration, bone fractures due to hypocalcemia, infection due to immunosuppression, inflammatory response, as well as adrenal crisis. Pharmacological treatments of Cushing's disease would include the following medications: ketonazole, mitotane, and hydrocortisone. And as well, treatments can include chemotherapy and radiation therapy. Now, surgical intervention for Cushing's would include microsurgical resection of an ACTH secreting pituitary adenoma is the optimum treatment for Cushing's disease, with cure rates of 80 to 90% if a tumor is found. Surgery is most often done through a transnasal transsphenoidal approach, which will not leave a visible scar. This type of surgery may be performed, per the surgeon's preference, using either a minimally invasive operating microscope or with the use of an endoscope. Partial removal of the pituitary gland, which is known as a subtotal hypophysectomy, may be used in patients without clearly identifiable adenomas. The following video will illustrate a microsurgical resection.
Cushing's disease is a debilitating endocrine disorder caused by an ACTH-secreting pituitary adenoma. In this case example, we demonstrate the pseudocapsule dissection technique for removal of these adenomas, as well as the utility of endoscopic inspection. Our patient has a 4-year history of progressive weight gain, hypertension, fatigue, as well as depression and easy bruising. Her hormonal evaluation confirmed elevated urinary free cortisol, serum cortisols, as well as elevated ACTH levels, and her MRI showed a well-defined but small microadenoma in the right aspect of the pituitary gland. Here in this short surgical video, the pseudocapsule dissection technique is demonstrated. The adenoma is the pale structure. The normal pituitary gland is being lifted upward after a small incision had been made into the gland. The tumor is then carefully dissected away from the normal pituitary gland using microdissectors. This progressive circumferential dissection results in devascularization of the tumor, and it becomes progressively pale as the dissection continues. It is then grasped with tumor forceps and is gently manipulated away from the gland, and in some instances we are able to completely remove the tumor in one piece. In this particular case, the pseudocapsule was quite soft and it was removed in several pieces. Here, final inspection shows no obvious residual tumor under microscopic visualization, and then using the endoscope, a more up-close panoramic view confirms no residual tumor being seen. The patient went on to make an excellent recovery. She was weaned off of prednisone replacement therapy over 1 year with complete recovery of normal gland function, and she remains in remission now 18 months after surgery.
Human flourishing is promoted through educating the patient regarding the importance of taking prescribed medications as indicated at the same time every day, and encouraging physical activity within the patient's limitations, as well as encouraging the client to eat foods high in calcium and vitamin D, and maintaining a safe environment to minimize the risk of pathological injuries. This is a poster I designed for Cushing's disease. It goes over several of the signs and symptoms, from the buffalo hump to the balding hair, the moon face, and the clinical manifestations. A major risk of Cushing's is women between the ages of 20 and 40 years, as well as a pathophysiology, some expected lab findings from blood glucose level down to the lymphocytes are decreased, the complications, some diagnostic procedures from X-ray and MRI, some different treatments of Cushing's from medications, chemo and radiation to microsurgical resection, and some lab tests from the 24-hour urine collection down to the dexamethasone suppression tests that can be conducted. Here's a summary of professional references, and I would like to take a moment to pay a short tribute to Dr. Cushing, who is known as the father of neurosurgery. The accomplishments of Harvey Cushing, known as the father of neurosurgery, is an inspiration to the medical profession. His inexhaustible energy and his painstaking attention to detail made him a superior surgeon, author, teacher, and scientist. These traits, combined with his unyielding devotion to the care of his patients, made him a legendary physician. His work in medicine led to the discovery of Cushing's disease, Cushing's syndrome, Cushing's ulcers, and Cushing's reflex. He contributed to the first continuous record for recording pulse and respiration. He became the first clinical researcher in the arena to advocate for the use of the newly discovered and mysterious X-ray. He performed the first human experimentation with nerve block anesthesia for operation, as well as the successful suturing of the thoracic duct without leakage as a student. He later introduced the sphygmomanometer into regular use in his operating room, despite other surgeons' contemporary belief that a physician's trained finger on a patient's pulse was of more use than the data produced by the confound contraption. From time to time, we need to take a moment to recognize and appreciate contributions made from amazing and wonderful individuals. Thank you, Dr. Harvey Cushing.